Hello and welcome back. And if you're new to the channel, my name is Tony Appleberg Parks, and I am a subject matter expert in risk adjustment, clinical documentation integrity, and medical coding revenue cycle in general. So um, I'm here to try to share some of that information to help with documentation practices that lead to better risk adjustment in the healthcare space. So, if you work anywhere near healthcare documentation, you've probably heard these terms thrown around. Um, they're interchangeable, right? CDI, medical coding, risk adjustment. Someone might say the coder flagged it, and someone else says CDI is asking about it, and someone else says this affects our risk score. And half of the room nods like they know exactly what that means, and the other half is just trying not to look confused, right? So here's the truth. They are three different jobs with three different goals, and they're done by three different people, usually, at three different points in the patient's chart. Um, Three different time frames in the revenue cycle. And mixing them up isn't just an awkward meeting moment. It can cost the practice real money, and it can create compliance risk, real risk. So today we're going to try to untangle this web for you for good. And by the end of this video, hopefully you'll know exactly what each role does and how they connect and why it's important to understand this. Why does it matter? All right, so let's start with why this confusion about all of this even exists. Because all three of these roles, CDI, coding, and risk adjustment, they're looking at exactly the same thing, sort of, the patient's medical record. So it's the same source anyway. So it's the same chart, same notes, and same diagnoses. And that's the source of confusion. If three people are staring at one document, it seems like it would make sense that they're all doing the same job, but they're not. They're asking completely different questions about that chart. The CDI specialist is asking, does this documentation actually reflect how sick this patient is? And the coder is asking, what are the correct codes for what's documented here? And the risk adjustment team is asking, do these codes accurately predict the cost of caring for this patient over the next year? So, three different questions in a sense, three different outcomes. And when people don't understand the distinction, you get duplicated work, contradictory queries to physicians, and in a worst case scenario, audits. So let's break each one down individually, and we'll start with CDI. CDI stands for Clinical Documentation Integrity. Sometimes you still hear people call it Clinical Documentation Improvement, which is the older name for the same field. At its core, CDI exists to close the gap between what actually happened to the patient clinically and what got written down in the chart. So here's the thing most people outside this world of CDI and these things don't really realize. Physicians are trained to treat patients, not to write charts that satisfy coding and billing requirements. A doctor might document that a patient has a low sodium level, and that's clinically accurate without ever writing the actual diagnosis, which is hyponatremia. Clinically, the doctor did their job, but from a documentation standpoint, that chart is incomplete because low sodium isn't a codable diagnosis the same way that hyponatremia is. And that's where a CDI specialist steps in. They review the chart, usually while the patient is still being treated or shortly thereafter, And if they see something documented in a vague or incomplete way, they send a query, which is a formal compliant question, back to the physician. It would be something like, you noted the patient's sodium was low and they were treated with fluid restriction. Can you confirm and document the specific diagnosis? CDI specialists are typically nurses or coders with clinical backgrounds because you genuinely need to understand pathophysiology to catch these gaps. So their whole job is making sure the chart tells the true, complete clinical story before that chart is ever coded. So medical coding happens after the documentation is finalized. If CDI is about making sure the story in the chart is complete and accurate, coding is about translating that finished story into standardized language. Really translating it, specifically ICD-10 codes for diagnoses, CPT and HCPCS, HCPCS codes for procedures and services. Think of the coder as a translator, not an investigator. A good coder doesn't diagnose the patient or interpret unclear documentation. They take what's clearly and compliantly documented and convert it into the codes that will be submitted on a claim. So if a physician writes type 2 diabetes with diabetic nephropathy, the coder knows exactly which ICD-10 code combination captures that relationship, and in the right order with the right level of specificity. This is precise, detail-heavy work. One wrong digit in a code or coding conditions in the wrong sequence can change reimbursement, trigger a denial, or misrepresent an encounter entirely. So coders go through extensive certification credentials, training, like they have like a CCS or a CPC. Commonly, risk adjustment coders have a CRC, Certified Risk Coder, specifically because the coding guidelines are dense and constantly updated. And here's an important distinction. If a coder reviews a chart and the documentation itself is vague or contradictory, they're not supposed to guess or infer. That's exactly the situation that should have been caught by CDI earlier, or it gets kicked back as a coding query. Coding depends entirely on the quality of what CDI helped ensure was documented. Now, risk adjustment is where things get less intuitive for people because it's not really about a single patient encounter. It's about predicting the cost across an entire year. So here's the concept. Insurance companies, especially Medicare Advantage plans, pay healthcare organizations differently depending on how sick their population is. You may have heard of managed care. A health plan that covers relatively healthy patients should get paid less per member than one covering patients with multiple chronic conditions, right? Because those sicker patients cost more to care for. They need more of everything. Risk adjustment is the system that makes the math work. It uses something called HCCs, hierarchical condition categories. Each HCC represents a category of serious chronic conditions: diabetes with complications, congestive heart failure, chronic kidney disease, and so on. Every patient gets a risk adjustment factor score, or otherwise known as a RAF score. It's based on their age, demographics, and which HCCs, or chronic conditions, apply to them based on their diagnoses that year. Add up the RAF scores across the health plan's population, and that determines how much funding that plan receives to do the care for that group of patients. So this is why risk adjustment teams, which are often coders with specialized HCC training, sometimes called risk adjustment coders or auditors, care so intensely about chronic conditions being documented every single calendar year. even if the condition hasn't changed. A patient's diabetes doesn't go away just because nobody wrote it down this year, right? But if it's not documented and coded annually, it disappears from that patient's risk profile and funding drops accordingly. And that's not fraud, that's the system working as it is designed. The fraud risk only shows up when someone documents conditions that aren't actually supported clinically, which is exactly why compliance and auditing are a big part of this world. And this is where your CDIs come in to help with that documentation integrity. Okay, so let's put all three side by side because I think seeing them together is what actually will make this click for you. CDI asks, does the chart reflect what really happened clinically? It happens concurrently, meaning it's while the patient is still in the hospital or shortly after the visit. In the case of outpatient CDI, it's probably happening the same day or before the claim drops. And it's typically done in the hospital setting by nurses or clinically trained specialists, more likely to be coders in the outpatient setting. Medical coding asks, what are the exact codes for what's documented? Now this is the coders that are just coding the diagnosis. So you have to understand that coding for risk adjustment or CDI is a different kind of coding. And doing CDI as a coder is not really coding. It's doing CDI, clinical documentation integrity reviews. And because coders are often the people doing them, that creates a level of confusion. It causes people to think it's all related, it's all coding. But in the actual coding process, medical coding asks what are the exact codes for what's documented. It happens after the documentation is finalized, and it's also done by certified coders. Risk adjustment is asking, do this patient codes accurately reflect their overall health risk for this year? Commonly, the way it's done now is risk adjustment coders are prepping charts and finding suspects and finding codes from previous diagnoses that have not yet been captured for the current year because it resets every year. So since it happens on an annual cycle, and we're often reviewing charts retrospectively across the entire patient population, it needs to be done by coders with specialized HCC and risk adjustment training. Sometimes the same people doing the regular coding, but usually it's a completely separate team. Okay, so now let's kind of zoom out and see how these three roles actually work together across one patient encounter, because they're not separate departments working in isolation. They're kind of in sequence. So it starts with the physician documenting the encounter. Then the CDI reviews that documentation, sometimes before the patient is even discharged. And if something is incomplete or unclear, they query the physician to get that, whatever it is, clarified. That's one way. The pre-charting and providing suspects is the other way. And the query is in the form of, this is the information I can give you about this diagnosis, why I think it's a suspect, and do you agree or disagree? So they have to choose whether they agree or disagree. If the physician agrees, then the code gets captured and submitted for risk adjustment. Once the documentation is finalized, the coder will step in and translate that documentation into ICD-10, CPT, or HCPCS codes. So that's actually coding out the chart. These codes go into the claim that gets submitted for payment. In some of the automated systems now, it's actually the provider who's putting in the diagnosis and code in the EMR, and those automatically go onto the claims. And so it makes the role of a risk adjustment specialist and CDI team that much more important to provide that education to providers and to ensure that the accurate and correct codes are being captured. If the patient has chronic conditions relevant to risk adjustment, and especially if they're covered under Medicare Advantage or another risk-adjusted plan, those same diagnosis codes also feed into the HCC risk adjustment model. Risk adjustment teams may go back and review the same chart again. Sometimes it'll be months later, and they're specifically checking were all the chronic conditions this patient actually has being documented and coded for the calendar year. This is retrospective reviewing. It's not the preferred way anymore. So one chart, one patient encounter actually flows through all the three roles sequentially, not simultaneously. And if any link in that chain breaks, like there's vague documentation, a miscoded chart, an HCC that got missed, it affects everything downstream: the claim, the compliance risk, and the funding that is tied to that patient's care. Okay, so let's kind of drive this home with an example. Give you a second to look at that. Okay, so a patient comes in for a routine visit. The physician note says that the patient's blood sugar has been running high lately, and they're on metformin. They have some numbness in their feet, and that's what's in the raw documentation. So a CDI reviews this and sees some red flags. High blood sugar plus foot numbness strongly suggests a specific, more complete diagnosis. So CDI queries the physician. Can you clarify, does the patient have diabetic peripheral neuropathy? Actually, that would not be a compliant query because we never want to lead the provider to the diagnosis. So instead, I would say we might say something like, is there a diagnosis associated with the elevated blood sugar concurrent with the foot numbness? Leave that open-ended. Okay. So the physician confirms yes, provides that diagnosis, and documents it clearly. And the diagnosis is type 2 diabetes mellitus with diabetic peripheral neuropathy. So now this is where the coder gets involved. With that clear documentation, the coder assigns the specific ICD-10 codes that capture diabetes with neuropathy, with the neuropathy complication. So it's not just a generic diabetes code, but the combination code that reflects the true complexity of this patient's condition. And finally, because this patient is on a Medicare Advantage plan, that diabetes with complication code does map to a specific HCC category. That HCC gets factored into the patient's RAF score, risk adjustment factor score, for the year. And this affects the funding the health plan receives to manage this patient's more complex, more expensive care. So now imagine if CDI never queried that vague note. The coder would have likely just coded diabetes unspecified with no complication captured. The patient's true complexity would be invisible in the data. The health plan would be underfunded for this patient's actual risk because these complications carry a heavier weight. And clinically, the record wouldn't even reflect that this patient has a real complication that needs ongoing monitoring. So one missed query, that's the actual dollar and cents impact on all of this. Now I'm going to throw a little fly in the ointment here. And this is where it's going to get a little bit messy. And this will help you to empathize with someone like me who works in all three worlds. So because these roles are so closely linked, they create friction. And if you've worked in this space, you already know exactly what I'm talking about. CDI specialists sometimes feel like coders are too rigid. They're only coding exactly what's on the page, even when the clinical picture clearly suggests more. Coders sometimes feel like CDI is asking physicians for details that go beyond what's clinically necessary, purely just to capture a code. And risk adjustment teams sometimes feel like neither CDI nor coding fully appreciates how much a single missed chronic condition affects an entire population's funding. While CDI and coding worry that risk adjustment pressure can tip into coding for dollars instead of coding for accuracy. Now, none of these tensions mean anyone's doing their job wrong. They just mean that these are genuinely different priorities sitting on the same chart. The healthiest organizations are the ones where these three groups actually talk to each other and regularly do so regularly instead of working in silos and blaming each other when a claim gets denied or an audit flags something. With all of these conflicting things as part of my role as a risk adjustment and coding manager, I maintain that accuracy is what's most important. As long as we're presenting an absolute, accurate, and truthful picture of the patient and their condition, no less and no more, then we're meeting all of these things. So what's the big deal beyond the internal job titles? Why is it important? First is revenue. Incomplete documentation and inaccurate coding directly means that claims get underpaid, or they get denied or flagged for audit. So it's real money walking out the door every single month for organizations that don't get it right. The second one is compliance. On the flip side, overzealous documentation or coding that isn't clinically supported is exactly what triggers those government audits, and they don't even have to be triggered anymore. They've ramped up their auditing capabilities to a point where everyone can just expect an audit. So, but why encourage it? So coding, documenting or coding what isn't actually supported may actually draw attention and trigger one of these audits and lead to paybacks, and in serious cases, fraud investigations. So this field lives right in the middle of that tension. This is exactly why it requires trained, careful people, not just software. That's why we will always need that human eye, even with all the advancements in AI. And the last thing, honestly, the most important one is patient care. A chart that accurately reflects a patient's true condition isn't just good for billing. It's the record that every future provider will read to understand the patient's health history. Vague documentation today can lead to a missed clinical picture for the next physician who treats this patient 5 years from now. And this is why that continuity of care matters so much. Okay, so let's bring this all together. CDI, and just kind of recap, CDI makes sure that the chart tells the true clinical story in real time while the patient is being treated. CDI may also look for those documentation deficiencies or gaps, or we could say risk adjustment does this, and present those to the provider. Medical coding translates that finished story into the standardized codes the healthcare system runs on. So that kind of coding is more commonly nowadays related to your billing department. And risk adjustment makes sure that these codes accurately reflect the patient's overall health risk. So year after year, and that's where we're looking for those gaps and trying to determine what needs to be addressed and things like that. Making sure that the code is captured compliantly with clinical validation that supports that code so that it can be captured. So ultimately that funding for the care is accurate. So the same chart, 3 different questions, 3 different timelines, 3 different but completely connected jobs. Sometimes one person is doing 2 of these things, or maybe all of them. Okay, so this is just my reference list. Basically, it's sources, and I've made sure to verify all of this information against the 3 sources to confirm accuracy. That said, I'm going to throw my disclaimer out. This is not legal advice. It's not medical advice. It's up to you to do your own research and confirm any information that I give you before taking any action on that. So with that, okay, anyway, that's the resources. We have one more slide. Okay, so that second number is no longer a valid number, but you can always reach out at the website, helpfordocs.com. And so if you have any questions, please place them in the comment area below, or reach out on the website form. So hopefully this helped clear up some confusion. And if you did get some value from the content, I hope that you'll hit subscribe so that I can keep bringing this to more and more people. We want the algorithm to recognize who this would be useful to. So I'm going to cover more of these behind the scenes breakdowns of how healthcare documentation actually works every week. So if your organization needs help with outpatient CDI, HCC auditing, or physician education, please reach out. That's literally what we do. And I want to thank you for watching, and I'll see you on the next one. Take care.